Good afternoon, everyone. This is Christine at Health Current, and thank you again for joining us for the program year 2021 Clinical Quality Measures eCQMs webinar. This presentation is provided through a shared commitment between Access, Health Current, and Myers and Stouffer to increase participation in the Medicaid Promoting Interoperability Program. Just a few logistical reminders today. Today's webinar is being recorded and will be posted on the Health Current and Access websites. All lines are muted, so please use the chat feature to ask questions throughout today's presentation. Just a reminder to include your name, practice, organization, and do not include any confidential information such as PHI. We'll be using a live polling today. Many of you have already started to engage in that. This is the poll everywhere. We have not, oops, sorry, looks like we're getting some background noise there. We would ask that you please follow the instructions here on the screen. If you're using your mobile device, please go to, or please text 22333 and text the word EO program 753 in your text message. If you're using your PC, please go to pollev.com, enter the EO program 753. This will allow you to respond to the poll in real time as well as see the results. We'll go just click here to the next slide. The instructions are right at the top again. And we encourage you to answer the question, where is your favorite place to vacation? And again, texting 22333 and enter the word EO program 753 on your mobile device will allow you to answer the question, where is your favorite place to vacation? Or you can use your PC by going to pollev.com and then enter EO program 753. With that, I will turn it over to Connie Ide to introduce our presenter today.
I am with you. Can you hear me?
I certainly can. Thank you.
All right. Well, we're very, very lucky today to have Priscilla Clark as a senior accountant for Myers and Stouffer, which is a certified public accounting firm that specializes in federal and state Medicare and Medicaid programs, as our presenter today. Many of you have heard her in the past. She is wonderful. She has a great knowledge and a great grasp of what is required for this program. So without further ado, Priscilla, you may begin your presentation.
Thank you, Connie. So today's webinar, as you can see, is going to be for program year 2021, and we will be covering the electronic clinical quality measures for meaningful use for the program. Next slide. So there's going to be 3 learning objectives that we're focusing on today. For you to know the CQM requirements for the Medicaid Promoting Interoperability Program, for you to understand the CQM documentation requirements, and third, for you to learn what resources are available to help you determine the appropriate CQMs to report on. Next slide. So what is electronic clinical quality measure? The electronic clinical quality measure uses data electronically extracted from the Certified Electronic Health Records Technology, otherwise known as the CERT, and/or health information technology systems to measure the quality of healthcare provided. The Centers for Medicare and Medicaid Services uses eCQMs in a variety of quality reporting and value-based purchasing programs. Hospitals, professionals, and clinicians use eCQMs to provide feedback on their care systems and to help them identify opportunities for clinical quality improvement. eCQMs are also used in reporting to CMS, the Joint Commission, and commercial insurance payers in programs that reimburse providers based on quality reporting. Next slide. So what are the reporting similarities between the PI and then other programs? So CMS has updated the eCQMs for potential inclusion in the following programs for EPs. First is the Quality Payment Program, which encompasses the Advanced Alternative Payment Models and the Merit-Based Incentive Payment System. Another program is the Advanced APM, which is the Comprehensive Primary Care Plus program. And then, as you're all familiar with, is the Medicaid, is also another program is the Medicaid PI program. So all of these programs listed do have some similarities with the PI program. So if you are attesting for those other programs, these clinical quality measures that you're using for the PI program can potentially benefit and help you in the other programs. Next slide. So eCQMs support achievement of healthcare goals. So what are those goals? The first one is better health. These eCQMs are being used and incorporated into the PI program to help promote evidence-based clinical processes, to help measure preventing and treating priority conditions, to improve outcomes by identifying deficiencies in safety and accessibility. The second goal is better healthcare. So to help reduce the provider burden, so examples of that could be administrative time by streamlining the measurements for the different patients that you're seeing. It can help improve functional assessment of chronic conditions, and it can also help facilitate care coordination across settings. The third goal is to lower costs. So it's to help reduce preventable hospital readmissions. It helps to decrease medication errors, and then also to promote appropriate usage of diagnostic testing and screening. There are three goals that eCQMs can help providers with. Next slide. So CMS guidance. CMS is moving from having each EP simply report eCQMs to having each EP's performance assessed based on the reported eCQMs. CMS is urging Medicaid providers to choose measures aligned with their practice. The agency advises reporting on measures containing numerators and denominators before reporting measures containing zeros. Now, please keep in mind that providers are allowed to report on eCQMs that have zeros, but CMS is recommending that you attest to the CQMs that where you're seeing patients in, they are being included in the numerator and denominator. Next slide. So here is a question. So if possible, should one of the 6 attested eCQMs be an outcome measure? So when you're going, whether it's on your phone or on the computer, so if you're using your phone, please text EO program 753 to 22333. So the number you're going to text is 22333, and then you will type out EO program 753, and then you will text A, B, or C. A for yes, B for no, and C for unsure. And the question is, if possible, should one of the 6 attested eCQMs be an outcome measure? So please give that your best guess, and we'll talk about the correct answer in a moment. I'll give you all about 10 seconds to respond. Please keep in mind you can use your computer to respond to the polling. Okay, I'm going to give y'all just a few more seconds to make sure to put in your answers right away if you can. So it does look like the majority of y'all got that right. So it is yes. So if you are able to, CMS does recommend that one of the 6 attested eCQMs should be an outcome measure. And we'll discuss more in the next slide. If you're not sure of what an outcome measure is, if that's not familiar to you, we'll definitely explain that. So we'll go to the next slide, please. So EPs must attest to 6 out of 47 available eCQMs. Out of those 47 eCQMs, there are 6 outcome measures, there are 27 high priority measures, and there are 14 remaining normal measures. So the first requirement that CMS sets forth, and some providers meet it, some providers may not meet that requirement, but we're going to call it the priority level 1. So if relevant, at least one eCQM should be an outcome measure. So if you see one of those 6 outcome eCQM measures and one of them is relevant to your practice, you should be attesting using one outcome measure. However, if you do not see any patients that fall underneath the outcome eCQM measure, it's not relevant to your to the provider's practice, then you would move to priority level 2. An example of it not being relevant to you, for example, say that the eCQM, one of them outcome measures is related to pediatrician patients. And so, but say that the provider you're testing for only sees cancer patients and none of them are under 18. So therefore that pediatrician outcome eCQM measure would not be relevant to that provider's practice. So you have to keep that in mind. So as you're attesting to these CQMs in the program, you need to make sure that the ones that you're attesting to are relevant to your provider that you're attesting for. So priority level 2, if no outcome measure is relevant, at least one eCQM should be a high priority measure. Keep in mind there are 27 high priority measures. So if none of the 6 outcome measures are relevant to the provider's practice, you move to priority level 2. And then you try to attest to at least one of your 6 being a high priority measure. Now, there are some instances where that is not relevant to a provider. So those 27 high priority measures are not relevant. So then there's 14 just normal remaining measures. And that's when you move to priority level 3. If no outcome or high priority measures are relevant, report on the relevant measures if possible. CMS wants to make sure that the providers that are attesting to this program are using the CQMs measures that are relevant to that provider's practice to help to meet that original goal that we discussed of better health care. So that's the reasoning behind all that. So but make sure you're trying to meet priority level 1, which is if relevant, at least one eCQM should be an outcome measure. And then if not, priority level 2, if no outcome measure is relevant, at least one eCQM should be a high priority measure, and so on. Next slide. Okay, next slide. Okay, so here is one of our polling questions. It says, which of the following eCQM reporting period is not allowed for program year 2021? There's 4 different options. So keep in mind for the first one, the first option is A, which is January 1st, 2021 through March 31st, 2021. So if you think that one is not allowed, then you would send in A as your response. The second response is B, which is June 1st, 2021 through August 29th, 2021. The second response, which is C, is July 15th, 2021 through October 12th, 2021. And the last option is October 1st, 2021 through December 29th, 2021. And the question is, which of the following eCQM reporting period is not allowed for program year 2021? So please put in your best guess, and we'll talk about that in just a few seconds. Okay, we'll give you about 5 to 10 more seconds, so make sure to go ahead and put in your responses. Okay, looks like there's 2 winners out there that each of you are thinking will not be allowed. So for program year 2021, as many of you are aware, this is the last year in the program. And so the eCQM reporting period must be 90 days for all providers, and the last day of the eCQM reporting period must be by October 31st, 2021. So answer D is correct. October 1st, 2021 through December 29th, 2021 will not be allowed for program year 2021 because attestations close October 31st, 2021. So you will need to make sure you have a 90-day reporting period, and that last day ends before or on October 31st, 2021. Next slide. So the definition of eCQM. So as established in the physician fee schedule rule, high priority measures for the PI program are determined via 3 methods. The first one is high priority measures under the MIPS program. The second one is measures included in the adult and child core set. And the third one is any additional measures selected by individual states. Please note that Arizona has not selected any additional high priority eCQMs. So there are only 6 high priority eCQMs that you can pick from. The EP must report on the most recent version of each eCQM available in the CERT. The eCQM reporting is 90 days for all EPs. And the eCQM reporting period must be within calendar year 2021. And the end of the eCQM reporting period must fall on or before October 31st, 2021. So make sure to keep that in mind because that is a key difference between program year 2020 and program year 2021. Next slide. So the electronic calculation versus the submission. So there's a distinction between CQM and eCQM. So CQM and CQMs can be calculated outside of the CERT. So via chart abstraction, there's multiple different ways. An eCQM is CQMs calculated electronically by the CERT. So the phrase eCQM does not indicate the data was transmitted electronically. eCQMs can be calculated electronically by CERT and still transmitted to the agency manually via attestation and EPIP. Keep in mind that all CQMs reported for purposes of the PI program must be calculated by the CERT. Therefore, the terms eCQM and CQM are used interchangeably for the PI program in many CMS resources, but definitely keep in mind that the CQMs for the PI program must be calculated by the CERT, and that's when you can pull out a CERT CQM report and then submit it to Access. So you want to make sure that report shows that you pulled it from the CERT. Next slide. So we mentioned briefly earlier the adult and child core measure sets. So CMS identified 2 recommended core sets of eCQMs, one for adults and one for children. We encourage EPs to report from the recommended core set to the extent those eCQMs are applicable to the EP scope of practice and patient population. CMS selected the recommended core set of eCQMs for EPs based on analysis of several factors. The first one is the conditions that contribute to morbidity and mortality of the most Medicare and Medicaid beneficiaries. The second is conditions that represent national public health priorities. The next is the conditions that are common to health disparities. Another one is conditions that disproportionately drive healthcare costs and could improve with better quality measurement. Another one is based off measures that will enable CMS, states, and the provider community to measure quality of care in new dimensions with a stronger focus on parsimonious measurement. And so parsimonious is the simplest model with the least assumptions or variables, but with the greatest explanatory power. Another thing that CMS relied on was measures that include patient and or caregiver engagement. So these ideas and these factors was what really built CMS and when they decided which CQMs to select, which core sets, what was going to be most beneficial to the providers helping out in this program. As you can see, there are 2 links towards the bottom. So when you are sent a copy of this presentation, you'll be able to click on those links at the bottom. And it takes you to 2 different websites. One is the adult core eCQM. So it lists out all the adult core CQMs that are available out there and are part of the PI program. Then the other link is the child core CQM. So that is just a list of all the child core CQMs that are associated with the PI program. Next slide. So here's a list of all 6 outcome measures. So at least one of the reported CQMs must be an outcome measure unless, of course, it is not relevant to the provider's practice and the patients that they see. As you can see in the next couple of slides as well, it's going to be these tables listing out the different CQMs for program year 2021. As you can see, for the first one is CMS 75. In that second column, you can see that says CMS 75 version 9. So each year the program has continued, it updates it to a new version. Now, some of your certs may not have version 9, but if they have version 8, that's fine, as long as you are attesting to the most recent version that is available in your cert. So CMS 75 is for children who have dental decay or cavities. We've also listed the NQF number, which is associated with a lot of these CQMs, as well as the QPP ID, and then what core set it's in. So each of these CQMs are going to be identified underneath the adult or the child core set, or just in general, it does not go with an exact core set, so that's where it's going to remain blank. As you can see for the second CMS, CQM, it's CMS 122, which is where in regards to diabetes. And that CQM is underneath the adult core set. The link at the bottom takes you to all the list of outcome measures and which website we pulled that from that CMS made public. So you can click on that link and go straight to it to see the full list of CQMs. Next slide. Here's a list of high priority measures, and there are 27 high priority measures. So the next couple slides are going to show you the remaining CQMs that are high priority measures. So keep in mind, if no outcome measures are relevant to the EP scope of practice, the EP must report on at least one high priority measure. So that's when you would go to this slide and the next couple slides to try to figure out, okay, which CQM is relevant to the provider's scope of practice and the patients that they see. Next slide. Here is, again, it's just continuing with the different CQMs that are underneath the high priority measures. Next slide. So then here's the remaining high priority measures. So if no high priority measures are relevant to the EP scope of practice, the EP may report on any 6 relevant measures. The link at the bottom takes you to the website where we pulled the high priority measures and how they were identified. Please keep in mind that CMS has not updated the list for program year 2021. However, there were no changes to the high priority measures. So the same high priority measures that were identified in program year 2020 have also remained as high priority measures in program year 2021. Next slide. For purposes of PI program, the eCQMs are calculated from the total patient population or subsets of the patient population based on age, condition, or anything along those lines, depending on what type of CQM it is. Data is not limited by payer. So the CQM should be pulling from all patients regardless of their insurance. So whether they are, they don't have insurance, whether they have Medicaid, Medicare, any type of public health insurance, that should not limit the CQM database and where they're pulling from. Next slide. So we're going to go over a few examples of CQM so you can kind of understand the types of eCQMs that EPs can test for. So one of those is the breast cancer screening, which is CMS 125. So it's a percentage of women 50 to 74 years of age who had a mammogram to screen for breast cancer. So that would be in the numerator, it would be how many women at that age had a mammogram. The denominator would be the women that were seen by the provider that are 50 to 74, regardless of if they have the mammogram or not. So there's also that link in blue, the measure specifications, which takes you to the CMS website and kind of gives you a breakdown behind the details of the CQM. So if you are interested in learning more about either one of these CQMs we're about to cover, you can definitely click on those links and go into the website and check that out. The second CQM example is for diabetes for hemoglobin A1C. And so it's a percentage of patients 18 to 75 years of age with diabetes who had hemoglobin A1C greater than 9% during the measurement period. And again, there's another link taking you if you want to know more details behind that CQM. Next slide. Another example is the antidepressant medication management, which is CMS 128. It's a percentage of patients 18 years of age and older who were treated with antidepressant medication, had diagnoses of major depression, and to remain on antidepressant medication treatment. 2 rates are reported. So the first one is A, which is the percentage of patients who remained on an antidepressant medication for at least 84 days, which is 12 weeks. The second one, which is B, is the percentage of patients who remained on antidepressant medication for at least 180 days, which is 6 months. This kind of breaks it down to where there are 2 different percentages underneath this clinical quality measure. So when you go to pull that report, it's going to look like it's actually 2 CQMs when really it's 1 CQM with just 2 different subpopulations underneath it. And then, of course, the hyperlink at the bottom would take you to the website to provide more details for this clinical quality measure if you're interested. Next slide. Okay, so here is a question. Does the EP's 2015 edition cert have to be able to calculate all 47 eCQMs? Again, the question is, does the EP's 2015 edition cert have to be able to calculate all 47 eCQMs? A is for yes, B is for no, and C is for unsure. Keep in mind that there are 47 total eCQMs, and then a provider must attest to 6 of those 47. So please put in the answer that you think is correct. We'll give you probably about 10 seconds to get those responses in, and then we will, I'll answer the question for y'all. Few more seconds, make sure to get your answers in. Looks like everyone is going with B, which is no. Okay, it looks like everyone is correct. The EP's 2015 edition cert does not have to be able to calculate all 47 eCQMs, but of course it does need to be able to calculate those 6 eCQMs, but it does not have to calculate all 47. Great job. Next slide. So the provider's 2015 edition cert must be used to calculate eCQMs for program year 2021. Certs may not be certified to calculate all 47 eCQMs. Providers should check to see which eCQMs their CERT is capable of calculating and select those that are relevant to their practice. If there is not a relevant eCQM that the CERT is certified to capture, EP should report on what their CERT is capable of calculating. If the older version of a particular eCQM does not match the EPIP layout, for example, the older version has multiple parts, but there is only one numerator and denominator space in EPIP, the EP should enter the numerator and denominators from the dashboard as closely as possible. So an example of this is as eCQMs are updated, you know, we discussed an example that had two subparts, so two percentages underneath the eCQM. So those two percentages, say for program year 2021, there's two of them, but for program year 2020, there was only one subpart percentage of the population. So in that example, EPIP may have two blank spaces for it, or two blank spaces for it, and say that your CERT has the older version for program year 2020, so it's only showing one numerator and one denominator, then just plug those numbers in, and then you would leave that second space blank. But of course, make sure when you are testing that you submit the report that you're pulling those numbers from. And so if Access does have any questions, they will reach out to you. But just try to fill that information in as closely as possible to what EPIP is showing and what your report shows. But if there are some minor differences, that's okay, and we will reach out to you if there are any questions regarding that. Next slide. Okay, so we have another polling question. Must the eCQM report show that it was pulled from the Practices 2015 edition CERT? A is for yes, B is for no, and C is for unsure. So must the eCQM report show that it was pulled from the Practices 2015 edition CERT? A is for yes, B is for no, and C is for unsure. I'll give you about 10 seconds to respond. The question is, must the eCQM report show that it was pulled from the Practices 2015 edition CERT? Okay, just a few more seconds to make sure to get those answers in. Okay, so it looks like an overwhelming majority of y'all did say yes, and that is correct. The eCQM report must show that it was pulled from the Practices 2015 edition CERT. So make sure the report that you're pulling, if it comes out of your CERT in Excel, make sure you screenshot steps that you took to pull that report out, because you must show how that report was pulled from the CERT. If it is a PDF and it has your CERT logo at the top and it looks like an official CERT document, that is sufficient as well. But just make sure it's showing somewhere on that report, or take screenshots of the steps that you're taking to make sure it shows it was pulled from the CERT. Next slide. So documentation requirements. The provider must run an eCQM report from the CERT for the appropriate reporting period. The provider must prove the eCQM data was calculated by the 2015 edition CERT. And so in other words, the report must show that the CERT name or edition, or screenshots demonstrating how the report was pulled from that CERT. The report should include the following items. It should show the required number and type of eCQM. So make sure there are 6 eCQMs, and that you are showing that you met a high priority CQM, or the other requirements depending on what is relevant to your provider's scope of practice. It should show the numerator and denominator for each eCQM. It should show the most recent eCQM version the CERT has available, and it should show the proper reporting period. The eCQM reporting period is 90 days for all EPs, and the eCQM reporting period must be within calendar year 2021, and the end of the eCQM reporting period must fall on or before October 31st, 2021. Next slide. So now we're going to discuss the audit findings and just some general things that happen during an audit. So all providers that receive a Medicaid PI incentive payment could potentially be selected by Access for post-payment audit. If selected, Access post-payment analysts will conduct a thorough review of the documentation attached to the EP's attestation in EPIP to determine if it meets the program requirements. Access may have follow-up questions or make additional documentation requests. Next slide. So some common audit findings. The eCQM report does not show it was pulled from the practices cert. So you need to make sure when you're submitting that CQM report that it shows it was pulled from your practice cert. Another common audit finding is failure to maintain documentation, and the practice no longer has access to the cert. Another one is reporting eCQMs for the wrong reporting period. Also, when a provider includes data for the entire practice no reported eCQMs rather than data for the individual EP. And the last common audit finding is not uploading the eCQM report when attesting for a payment. If you meet any one of these 5 items, Access will be reaching back out to you to make sure you submit the correct documents, that it's showing the correct things that it's supposed to. So make sure when you go to submit that eCQM report that it meets all the documentation requirements. Next slide. So here are the list of resources that we use to compile this presentation. The first one is going to be the CQI Resource Center, which has a list of all the CQMs that CMS has put forth in this program. And it does show each of the program years. So the full list of CQMs for each program year. So make sure when you go to that website, you're actually clicking on the correct program year. Another one is the CMS CQM tip sheet. So you can click on these links and they're going to take you straight to where you're supposed to go, where we pulled our information from. Another one is the Federal Final Rule, which covers modified stage 2 and stage 3. The next 2 links are the adult core eCQM and the child core eCQM. And those are the links that we referenced throughout the presentation that just shows a full listing of each of those CQMs underneath each core set. The next link is the 2021 eCQM. So it's a full listing of all 47 eCQMs for program year 2021. And it does identify which ones are high priority versus the regular eCQMs. And then last but not least is the Access Program Year 2021 eCQM frequently asked questions. And so it kind of gives you some instructions once you go to the Access website where to click. And these items, so this webinar and then also the FAQ should be made available on the website within the next few weeks. At this point, we're going to open it up for, if you have any questions, please feel free to put them in the chat box and I can answer those questions for you. Christine, do we have any questions at this time?
So sorry, Priscilla, I had my cursor on the wrong screen. There have been no questions that have come through the chat as of yet, but I'm also happy to bring up your FAQ document if you would like.
Yes, that would be great. So we put together a frequently asked questions document to kind of help you in case you have some questions after the webinar. And these questions can get you thinking regarding what is going on in the program. And any questions, it could spot check some of your questions. It could lead to you having additional questions. So I'm going to read through these questions for you. And then, again, if you have any questions, feel free to put them in the chat box and we'll answer them on this call. So the first question is, what is electronic clinical quality measure? So an eCQM uses data electronically extracted from the CERT and or health information technology systems to measure the quality of healthcare provided. The Centers for Medicare and Medicaid Services uses eCQMs in a variety of quality reporting and value-based purchasing programs. The second question is, what is the difference between a CQM and an eCQM? A CQM can be calculated outside of the CERT, whereas eCQMs, which is the electronic CQMs, are calculated electronically by the CERT. The phrase eCQM does not indicate the data was transmitted electronically. An eCQM can be calculated electronically by CERT and still transmitted to the agency manually via attestation in EPIP. All CQMs reported for the purposes of the PI program must be calculated by the CERT. Although the terms eCQM and CQM are used interchangeably for the PI program, only CQMs generated by the CERT are accepted as sufficient for the program. The next question is, where can I find eCQMs I can report for each program year? So one of the resources we did provide to you is to go to the eCQI Resource Center, and there's the link again, and you select the appropriate year from the Select Performance/Reporting Period drop-down menu, and it kind of just walks you through the steps of what to do, what to click to get to the program year that you are testing for. So even if you're testing for program year 2020 currently, you can go to that same link and just make sure to click the appropriate program year, and you'll get the full listing. The second paragraph right there tells you which list to download to get the full listing, because there's multiple different documents on the website that are referenced. So make sure you click on the correct document name to see the full listing. The next question is, how many eCQMs must the EP report on for program year 2021? The answer is an EP must attest to 6 out of 47 available eCQMs. We recommend that the EP run a complete eCQM report from his or her cert in case of vendor or other issues. EPIP will only allow the EP to attest to exactly 6 eCQMs. However, the cert eCQM report contains more than 6 eCQMs. So when you are testing an EPIP, you're only going to be able to enter in 6 CQMs. However, when you submit the PDF report or the Word or Excel report to access via EPIP, that report, we recommend that it contain the full listing of CQMs that your cert can calculate, just in case there's something you run into down the road or you stop using that cert. So when you are, if you are selected for audit, you're able to select the correct report. And if there's any issues with the 6 you attested to, we're still going to see, for example, 12 other CQMs that could potentially work for your provider. Okay, moving on to question 5. I don't see any questions in the chat box, but again, if you have any questions about any of this, definitely feel free to put that in the chat box. So question 5, what is an outcome measure? An outcome measure is a high-level clinical measure used to measure a change in the health of patients. Some of the outcome measures for 2021 focus on diabetes, cataract, high blood pressure, and dental decay in children. An outcome measure is different from a process measure, which measures a specific healthcare process, such as screenings and monitoring of patients. For program year 2021, there are 6 outcome eCQMs. Moving on to question 6, what if no outcome measures are relevant to the EP? The answer is an EP must attest to at least 1 outcome measure unless no outcome measures are relevant to the EP. In this case, the EP must report on at least 1 high priority measure. So that leads to this next question, what is a high priority measure? The answer is that CMS has flagged certain eCQMs as high priority. These measures focus on specific health conditions that represent national public health priorities. And keep in mind there are 27 high priority measures. So the next question, question 8, is what if no high priority measures are relevant to the EP? The answer is that if no high priority measures are relevant to the EP scope of practice, the EP may report on any 6 relevant measures. And that leads us also to the next question, which is what does relevant to my scope of practice mean when reporting eCQMs? The answer is the EP should report on measures that best reflect the types of services the EP provides and the EP's patient population. For example, if the EP is a pediatrician, he or she may select the childhood immunization status, which is CMS 117, as a relevant eCQM. Use of high-risk medications in the elderly, which is CMS 156, would not be a relevant eCQM for a pediatrician. Ultimately, it is up to each EP to determine which eCQMs are most relevant to the EP scope of practice. Moving on to question 10. What if the EP cert is not certified to capture the most relevant eCQM? For providers EHR technology to be certified, the Office of the National Coordinator, which is the agency who certifies that an EHR solution meets the PI incentive program requirements, the Office of the National Coordinator requires the EHR technology solution to support a provider that is reporting its eCQMs for MU purposes. However, ONC allows vendors to certify selectively which eCQMs their software will support. This means it is very important for a provider to understand which eCQMs a cert will support. Depending on the population a provider serves, the provider may find that some certs may not support the reporting of the eCQMs applicable to that practice. if there is not a relevant eCQM that the cert is certified to capture. The EP is able to report on what the cert is capable of calculating. So make sure to keep that in mind when you go to look at the list of eCQMs that your cert has made available to you. Make sure that there are at least 6, and then you should report on the ones that are relevant to you if possible. Okay, we're going to move on to question 11. I do not see any questions in the chat, but again, if you have any questions, feel free to put them in the chat and we can answer them during this call. Question 11. Does the state of Arizona have any additional high priority eCQMs? The answer is that Arizona has not selected any additional high priority eCQMs, and EP should only use the list of 27 eCQMs that CMS identified as high priority. Question 12, how long is the eCQM reporting period for program year 2021? This is especially important because this did slightly change from program year 2020. The answer is that the eCQM reporting period for program year 2021 is 90 days for all EPs. The eCQM reporting period must be within calendar year 2021, and the end of the eCQM reporting period must fall on or before October 31st, 2021. Question 13 is, does the eCQM report have to come from the cert? The answer is yes. The numerator and denominator information for eCQMs must be reported directly from the cert report. Question 14, how do I run an eCQM report from the cert? The answer is that if the EP does not know how to pull the eCQM report directly from the cert, the EP should contact the cert vendor and request guidance. Question 15, how should a provider who upgrades from a 2014 edition cert to a 2015 edition cert or changes cert vendors report during the 90-day eCQM reporting period in 2021? The answer is that EP does not need to have a 2015 edition cert by the beginning of calendar year 2021 or the beginning of the eCQM reporting period. The data that Medicaid EPs are required to report for eCQM is a snapshot based on the data within the cert, taken between the end of the PI reporting period and the date of attestation for the reporting period. So the first one is EPs have a 2014 edition cert during the eCQM reporting period and upgrade to a 2015 edition cert of the same cert prior to the attestation. So we're going to look at this example first and to determine what the steps the provider must take. So in that example, we have a provider that has a 2014 edition cert at the beginning of the eCQM reporting period, but then at some point before the end of that 90-day reporting period or prior to the date of attestation, they upgraded to that 2015 edition cert, okay? So the data supporting eCQMs is entered into the EP cert during the regular course of business and will be stored in the cert. The cert should retain data entered into the 2014 edition within the upgraded 2015 edition. And that data is staying consistent because you're still staying within the same cert. So even though you're upgrading your cert, you're using the same organization. So the cert should retain data entered into the 2014 edition within the upgraded 2015 edition. The EP should generate an eCQM report between the end of the PI reporting period and the date of attestation. And this report will calculate the eCQMs based on the data entered during that PI reporting period, or otherwise known as the eCQM reporting period. Okay, the second scenario that we're going to look at is EPs that change vendors or practices during the reporting period. So you're not using that same cert anymore. You're actually changing which company you're using, or you're switching in between practices. So for that example, the EP must provide 2 reports, one from each system or location, depending on whether you're switching vendors or you're switching the practice location. This will show the reported eCQMs from both certs or locations. Both reports should cover the entire PI reporting period. The numerator from both reports should be added together to determine the numerator entered into EPIP, and the denominators from both reports should be added together to determine the denominator entered into EPIP. So say you're attesting for a provider, that provider has changed vendors, okay, during the eCQM reporting period. What you're going to need to do is pull the eCQM reporting period from both certs. So say you're using Athena for the first 60 days and the last 30 days you are using Epic. You're going to need to submit both of those eCQM reports into EPIP when you're attesting. But when it comes to each individual eCQM that you're attesting to, you're going to take the numerator from the Athena report and the same numerator for that same CQM, or different numerator, same CQM from the EPIC report, and you're going to add those numerators together. So say you saw 5 patients in the numerator for the diabetes eCQM in Athena, and you saw 6 in the EPIC report. That's going to be a total of 11 that you're going to put key into EPIP when you put in that numerator. And you're going to use the same steps for the denominator and all the other eCQMs that you attest to. And again, if you have any follow-up questions, make sure to put that in the chat and we can get that answered. Or if you have an example of one of your providers, feel free to put that in the chat. Leave out any PHI, but we can answer that question for you. Okay, we'll move on to the next question. If no one puts any questions into the chat, which I'm not seeing anyone putting any questions in the chat yet. So we'll move on to question 16. The eCQM specifications are updated each year. Which year specifications or versions will Arizona accept from providers? The answer is that vendors are not required to update each year to the latest eCQM specifications in order to retain their 2015 edition certification. Therefore, it is possible that Medicaid providers will have certs that produce eCQMs specified to a variety of years. Arizona will accept the most recent version for each eCQM. Arizona will allow providers to report on older versions if that is all the EP's 2015 edition cert is able to produce. If the older version does not match the EPIP layout, the EP should enter the numerator and denominators from the dashboard as close as possible. Moving on to question 17. For the Medicaid Promoting Interoperability Program, can I report an eCQM with a 0 result in the numerator and or denominator? The answer is a 0 result in the numerator and or denominator may indicate the eCQM is not relevant to the EP scope of practice. While we strongly encourage providers to report relevant eCQMs, which are measures that have numerators or denominators greater than 0, 0 is an acceptable result provided that this value was produced by a cert. Moving on to question 18. Why does CMS recommend EPs report from the adult and child core eCQM sets? The answer is that core measures are national standards of care and treatment processes for common conditions. These processes are proven to reduce complications and lead to better patient outcomes. CMS selected the recommended core set of eCQMs for EPs based on analysis of several factors. The first one is conditions that contribute to the morbidity and mortality of the most Medicare and Medicaid beneficiaries. Another one is conditions that represent national public health priorities, conditions that are common to health disparities, conditions that disproportionately drive healthcare costs and improve with better quality measurement, measures that would enable CMS, states, and the provider community to measure quality of care in new dimensions with a stronger focus on parsimonious measurement. And the last factor is measures that include patient and or caregiver engagement. So all of these different factors have helped CMS to select the best recommended core set of eCQMs for the EPs to attest to. Moving on to question 19. Can I submit my eCQM in electronic format directly to the state? The answer is that Arizona is not currently able to accept electronic submissions of eCQM. The eCQM report will need to be uploaded to EPIP during attestation. Moving on to the next question. We have about 10 minutes left of the webinar, so if you do have any questions, make sure to go ahead and put them into the chat. We have 2 more questions that we'll go through on this frequently asked questions document. Question 20, what is the difference between program years 2020 and 2021 for eCQMs? The answer is the following changes occurred between program year 2020 and 2021 for meaningful use. And that is the eCQM reporting period for program year 2021 must be within calendar year 2021. And the last day of the eCQM reporting period must fall on or before October 31st, 2021. Question 21 is, what should an EP do if during the EPIP attestation process, the eCQM section does not allow the EP to report on the eCQM most relevant to your practice? The answer is that Access does not anticipate this occurring, but if it does, please email EHR incentive payments at azaccess.gov and alert them of this issue. The EP should continue to attest to the best of his or her ability, write a letter of explanation, upload it to EPIP if possible. So hopefully that will not occur at all. But if any point during that time you have any concerns with the testing in EPIP or you have some questions, definitely feel free to reach out to the team and we would be more than happy to answer any questions that you have. And I do not see any questions in the chat box. If you have any last minute burning questions, make sure to put them in the chat box and we can go ahead and answer that. And there's also the contact information here for Access and Health Current, and there's the email and then the phone numbers to go along with that. So if you do have any questions after this webinar is concluded, you can definitely feel free to reach out via email or phone to ask any questions you may have regarding the program.
Thank you so much, Priscilla. This has been a great presentation, and thank you for all who participated in the polling. Just a reminder that that chat box is open if you do have questions for Priscilla. We'll certainly get those answered, or you may use the email addresses or phone numbers on the screen. Just a reminder that we have recorded this presentation and we will email a copy of it out to everyone that has been participating, along with the FAQs that you see here. Again, these will be posted both to the Health Current and Access websites. With that, with that, Priscilla, I do not see any additional questions in the chat box, so I think we'll give everybody just a few minutes back to their day. Again, appreciate everybody's time. Thank you again for joining us. Have a wonderful afternoon.